Let's study about hypopituitarism and panhypopituitarism, that is hyposecretion of anterior pituitary. So this may be result this may be due to pituitary factors or hypothalamic factors. Pituitary or hypothalamic factors. So what is the etiology? They can be congenital diseases of hypothalamus like deficiencies of GnRH that is present in Kalman syndrome, deficiency of TRH and deficiency of GHRH, acquired hypothalamic that is craniopharyngioma, sarcoidosis, tuberculosis, histiocytosis, X, surgery, radiotherapy, tumors, and head trauma. These two result in the hyposecretion of hypothalamus. Pituitary. Pituitary factors are pituitary adenoma, postpartum necrosis, autoimmune like lymphocytic hypophysitis, surgery, radiotherapy, hemorrhage that is pituitary apoplexy, empty sella syndrome, and hemochromatosis. So, what are the clinical features of hypopituitarism? Clinical features are depend on the underlying lesion. If hypopituitarism is secondary to pituitary tumors, so there will be mass effects like headache, visual impairment, diplopia, electrolyte alterations, disorders of the autonomic nervous system that are produced by the hypothalamic involvement may be present. With progressive lesion, that is non-functioning pituitary tumors, there will be sequential loss of hormone secretion. Ultimately, the patient will go into coma and will result from because there will be hypoglycemia and water intoxication and hypothermia. So let's see what will be the features when these hormones will be deficient. First is growth hormone deficiency. This is earliest to occur, बट इसका कोई सिग्निफिकेंट सिम्टम नहीं आएगा एडल्ट्स में. एज एडल्ट्स में जो डिवाइडिंग प्लेट होती है वो फ्यूज़ हो जाती है, तो इसलिए एडल्ट्स में कोई सिग्निफिकेंट सिम्टम नहीं आएंगे. बट ऐसा हो सकता है कि इंक्रीज्ड रिस्क हो जाए फ्रैक्चर्स का, या फिर जो कार्डियोवेस्कुलर रिस्क प्रोफाइल है वो इंक्रीज़ हो जाए, क्योंकि ग्रोथ हार्मोन जो होता है वो विसरल फैट मतलब ग्रोथ हार्मोन की डेफिशिएंसी की वजह से विसरल फैट या फिर इंक्रीज्ड एलडीएल और रिड्यूस एचडीएल की वजह से कार्डियोवेस्कुलर रिस्क प्रोफाइल जो होगी वो बढ़ जाएगी. एंड देयर इज़ डिक्रीज क्वालिटी ऑफ लाइफ. अगर हम चिल्ड्रंस की बात करें तो उनमें ग्रोथ हार्मोन डेफिशिएंसी के क्या फीचर्स आएंगे कि जो फाइनल हाइट होगी वो उनकी कम होगी, डिक्रीज्ड लीन बॉडी मास होगा एंड हायर फैट मास होगा. नाउ लेट्स स्टडी अबाउट द डेफिशिएंसी ऑफ एलएच दैट इज़ ल्यूटिनाइजिंग हार्मोन. अगर एलएच की डेफिशिएंसी होगी तो उसकी वजह से मेल्स में लॉस ऑफ लिबिडो और इम्पोटेंस होगा एंड ओलिगोमेनोरिया या एमिनोरिया, विजाइनल एट्रोफी एंड हॉट फ्लशेस हमें फीमेल्स में देखने को मिल सकते हैं. लेटर इन लाइफ क्या हो सकता है कि जो मेल्स हैं उनमें गायनेकोमेस्टिया एंड डिक्रीज फ्रीक्वेंसी ऑफ शेविंग देखने को मिल सकती है. एंड बोथ सेक्सेस में एलएच डेफिशिएंसी की वजह से इनफर्टिलिटी एंड ओस्टियोपोरोसिस हो सकता है. एंड एक्सिलरी एंड प्यूबिक हेयर जो होंगे वो स्पार्स हो जाएंगे एंड स्किन जो होगी वो फाइनर एंड रिंकल्ड दिखेगी. Now let's study about ACTH deficiency. Due to ACTH deficiency, there will be deficiency of cortisol, जिसकी वजह से हमें साइंस एंड सिम्टम्स आएंगे एड्रिनल इनसफिशिएंसी के. एग्जाम्पल फटीग, वीकनेस, डिजीनेस, नोजिया, वॉमिटिंग, हाइपोटेंशन, हाइपोग्लाइसीमिया एंड वेट लॉस विथ स्किन पैलर. not skin hypopigmentation but skin pallor due to lack of melanin and normal plasma electrolytes. TSH deficiency. TSH deficiency leads to symptoms and signs of secondary hypothyroidism. There will be tiredness, cold intolerance, constipation, weight gain, hair loss, dry skin, bradycardia, hoarseness, slow mental processes. Due to prolactin deficiency, there will be failure of lactation. Now, we can see one feature that is due to electrotroph cells. If they are involved, you can see if prolactin levels are increased, that is due to कि हाइपोथैलेमस की जो इनहिबिटरी सिग्नल्स हैं लेक्टोट्रॉफ्स पे वो नहीं है. So that's why there will be increase in prolactin levels. And अगर पिट्यूटरी डैमेज हो गई है then also there will be lower prolactin levels. If there is compared to primary adrenal insufficiency, ACTH deficiency doesn't cause salt fasting, or volume contraction or hyperkalemia because it is not clinically important कि वो deficiency करवाए aldosterone की. So that's why ACTH deficiency होगी उसमें pallor दिखेगा ना कि hyperpigmentation दिखेगा. The laboratory investigation to confirm hypopituitarism are: they can be demonstration of low levels of trophic pituitary hormones in the setting of low target hormones. However, sometimes level of trophic hormones may be normal. If there is low free T4 with low or inappropriately normal TSH. Low early cortisol with low or inappropriately normal ACTH, low testosterone without elevation of gonadotrophins, low IGF-1 level, that is an indicator of growth hormone deficiency because growth hormone acts through insulin growth factors. So if there is low level of IGF-1, then it represents that there is growth hormone deficiency. Provocation tests that may be required to assess pituitary reserve. First is growth hormone response to insulin-induced hypoglycemia, L-DOPA, or combination of arginine and GHRH. Insulin-induced hypoglycemia is considered the gold standard test. Next is prolactin levels fails to rise after TRH. ACTH response as assessed by measuring cortisol response to insulin-induced hypoglycemia, CRH or metirapone. TSH response to TRH. What is the management? If there is ACTH deficiency, we will give cortisol 20 mg in the morning and 10 mg in the evening, or we can give prednisolone 5 mg in the morning and 2.5 mg in the evening. These doses should at least be doubled during acute illness and administered without delay by intramuscular or intravenous injection in patients who are vomiting. If there is TSH deficiency, we treat it with T4 0.1 to 0.15 mg daily with the aim of maintaining free T4 in the upper quartile of normal range. T4 should not be administered until adrenal function has been evaluated and either found to be normal or treated. Gonadotrophin deficiency is treated with sex hormones like testosterone and estrogen progestin replacement based on the age and sex of the patient. Men and women who wish to be fertile should be given gonadotropins. Thank you for watching. Like and subscribe.